Well, hello there again, class. This is Colleen Hargreaves, part 2, hypertension. And this should be a topic that is of utmost importance to you because really it's something that nurses very much are required to do. It's a skill as well as a knowledge base. So let's get right into it. As blood pressure increases, so does the risk of, okay, so that heart over there, I have a little picture of a heart. I should have it with a little bit of a brain and kidneys in there too, because really the three organs we worry about are heart, brain, and kidneys, and not necessarily in that order. 1 out of 3 adults is affected. That's a very large percentage of the population. Healthy People 2020 has it as their goal to reduce the risk of the modifiable risk factors, okay? And that's something we'll talk about. What is that modifiable risk factor that we can start targeting in on? We know that a lot of people don't have awareness that they're hypertensive. And if that's the case, we may be the first person that's checking their blood pressure to let them know something's not really where it should be. So nurses have to have a good working knowledge, because we oftentimes are the people that help people understand. And yet we also know, and that's why this is a skill even now, please keep practicing all the way through your nursing training, because it's something that you'll get more and more comfortable as you clinically look at the situation, what's going on. You become a little bit of a sleuth, saying, all right, let's recheck, because it fluctuates, right? So what's an ideal condition for checking blood pressure to get a good baseline? We're all about that. Now we have to remember again the pathophysiological approach, so we understand what contributes to underlying hypertension, right? And we know blood pressure, what is it? It's cardiac output times systemic vascular resistance. So anytime in your reading you see SVR, it stands for the systemic vascular resistance. Okay, make a note of that. Here we have another way to look at it through the pathophysiological view to say, it affects the cardiac contractility and conductivity. The sympathetic nervous system is involved. We have hormonal influences, then you have renin, angiotensin, aldosterone system, RAS. These are all, it's multifactorial. So when we say, well, what's making that blood pressure go up? A lot of things could be doing it, or, one specific thing, but nonetheless, it's not an easy, guess. You have to really do some investigation before you can understand what's happening. So this is where, again, it's a good review. Sympathetic nervous system, the fight or flight. We say, yeah, of course, we have to get out of danger. Cardiac output is increased, and that the body is also saying, well, I don't want to get overloaded with this volume of blood that's coming at me. What can I do? So there's that little ebb and flow, trying to keep us from over response, right? So this is why it's important to understand the things that we can control versus the things we can't control, and the recovery process, right? So fight or flight, we also have to know there's also ebb and flow. So think of that too. How do we recover? Just like every heartbeat has the systolic and diastolic, right? The heart movement, activity versus rest. We need that ebb and flow. Baroreceptors, and we talked about that a little bit. It's in the carotid arteries found there, and that's really monitoring the volume. So it's going to detect when things are in the more normal realm, and it's there for homeostasis, because the baroreceptors are really looking for just the maintenance, right? The blood pressure stability during normal activities. So when someone is having to get up and do something quickly, more blood volume will be released, and it's not going to affect the blood pressure drastically. But blood pressure does go up and down, but there's within ranges of safety up and down and recovery, right? But over time, when it's really out of range, the baroreceptors can adapt and become, where that hypertension becomes the new normal. And that's the danger. That's why people don't have symptoms many times. All right. So we have the vessels themselves that have vasoconstricting substances that will kind of limit how much blood flow can come through, because it can get damaging, right, if that pressure comes in too hard. The renal system also is looking at volume, what's being filtered, filtration rate, and the renin, angiotensin, aldosterone system, which is very much about the up and down of flow and how the body's going to respond, like when the kidneys secrete the renin in response to the central nervous system, right? You say, okay, there's decreased blood flow through the kidneys, and we're decreased sodium concentration. So renin is an enzyme, and it converts angiotensin to angiotensin 1. And then once angiotensin 1 is converted to angiotensin 2, that comes through a converting enzyme, angiotensin converting enzyme ACE. So you say, oh, okay, so if we're trying to reduce blood pressure through that conversion, that's where the ACE inhibitor comes in. It's interrupting that angiotensin 2 formation, okay? So these all should really kind of help you understand some of the medication selections and why one thing is going to work better than another. When you look at the endocrine system, this is again the fight or flight, epinephrine, norepinephrine. Sometimes people say noradrenaline, and that helps you understand the adrenal medulla. Okay, it's coming from that sits right on top of the kidneys. So that's right there, like very conveniently located to say, hey, we need more blood pressure. We need it raised up, because if it's going to be raised up, it's going to influence cardiac output, right? So that's where it gets us. That fight or flight will help us get out of danger. It's a primitive type of protective system that we've been given. But then we have something, aldosterone, and the aldosterone can start to become part of the reality, because it says A2 stimulates the adrenal cortex to release aldosterone. All right, aldosterone stimulates the kidneys to retain sodium and water, and this increases blood volume and cardiac output. So over time, if we're constantly being stressed, we're going to start producing kind of cortisol and these hormones that really do they stem from the kidneys, okay, in response to chronic stress. And it has a steroidal type of effect. So if you have a retention of sodium and water, that's where weight gain, that's where cortisol, we know, helps contribute to weight gain. So we got to help that person be less stressed, find ways of coping differently, right? ADH from posterior pituitary gland, ADH, which is antidiuretic hormone. We know that if you have a diuresis, that's a form of letting go of fluid. So antidiuretic means you're holding on to fluid. So again, it's really just what's being left in the system to create elevated blood pressure. Okay, that kind of should make sense. So now you say classification, get to know these, because the new normal is under 120 and under 80. Okay, so under 120 systolic, under 80 diastolic. Pre-hypertension is the old 120 over 80. We got to get it lower than that. Knock off, I always say knock off 5, strive to be in a lower setting. And that's your baseline. Okay, your hypertension stage 1, 140, 90, you say, okay, that's getting to be in the treatable range. Although sometimes doctors will allow people to do some lifestyle adjustment, maybe at that point, but some people are not a good candidate for that. They may have, severe arthritis or something that prevents them from exercise, and they're limited in some ways. They might want to treat it right away and then work on the lifestyle over time. Stage 2, remember 160 over and the diastolic 100. That's really getting dangerously high. So that's why it's good to know this area when it really becomes something we shouldn't ignore, and advising people to go for medical follow-up. So defining hypertension, what is that, right? Primary hypertension, also known as idiopathic hypertension, which usually means we don't know fully the identified cause. We're not sure. And again, when you look at that spill out of factors that contribute, it's understandable that it takes some investigation before you really, when you understand how complicated the pathophysiology is. It's multifactorial. That's another way to think about it. 90 to 95% of all cases, that's pretty much almost everybody. Okay, so that's why we have to really get ready to talk to somebody, explain to them, do a good assessment, subjective as well as objective, but subjective in this case, you really want to dig in to find out what could be contributing. The etiology of hypertension, secondary, we want to say, okay, there's usually a direct cause that's clear. And I know in your books, I think under one of the pages here, I found a good chart that does say, yeah, it's on page 684, and it's table 32.3, and it gives you several causes of secondary hypertension, and that's good for you to look through, because it really does help you understand that some things are just temporary, that somebody develops a hypertension. And that's your secondary. So it's, we do know about, it's not an exhaustive list. It's like 1, 2, 3, 4, 5, 6, 7, like eight items. If I had you in class, I'd probably break you up into groups on this particular one. What is contributing? What causes that? And again, for your next semester, when you learn about OB, we know about toxemia. Yeah, usually once the baby's born, the blood pressure is normalized. But there are some cases, percentage of cases, where it could have tripped an underlying hypertension that was there too, and now that person will have to be on antihypertensive medications for the rest of their life. You know, there are cases like that. Okay, so now we say for primary hypertension, what are the primary prevention, secondary prevention? This is more when we're looking at primary prevention is always thinking these are things that become really pretty well in a physical. These topics should come up for reducing our risk of ever developing high blood pressure. Okay, and I think I might have mentioned the blue zones in class, but there are parts of the world where people are never hypertensive in their lifetime. Okay, so and because of all of these things that really make it just doesn't develop. Where in the secondary, this is kind of more modern society, we say, oh yeah, we know that a lot of these things are contributing, and these are done usually through screenings. So we know there's certain age-appropriate screening where we expect to see high blood pressure start to develop. Talking about people's alcohol use, it's important that we are ready to educate the public as to what is moderate use. Moderate use is 1 drink of alcohol a day for a woman and 2 for men. That's moderate. The minute you go into twice that recommendation, now you're into heavy. And beyond heavy, it's abusive. Okay? So really, we know heavy and abusive area is when alcohol becomes the secondary prevention. We got to get people to reduce or eliminate entirely. Tobacco use, you know, again, you're dealing with the arterioles, the vessels damaging. You're damaging them. It's a circulatory damage, not just the lungs, but that goes on. Diabetes, we know, is a multi-system issue and an organ issue. So, of course, it affects the whole body. Our lipids and sodium, these are all things that can either increase volume with the sodium, and then the lipids are really narrowing blood vessels, right, and gender. So those are things that we'll just always be working on, okay? And it's interesting that with the water and sodium retention, there's only 1 in 3 people who consume high sodium diets develop hypertension. And that's why there's a lot of people who say, oh, that's a lot of hogwash. High salt doesn't affect me. And some of that may have a genetic component. There may be some truth to that. So it can be frustrating because many times that is a big indicator. We eat much more salt than we ever did. So to sell that can be tough. Research doesn't always back our results. But then again, 1 in 3 people have high blood pressure too, so it's kind of interesting. So these are important to remember, the pathophysiology, so we can take it, it's like the old take it with a grain of salt. No, but you really do want to listen to people, and just active listening is very important in part of the investigation, and helping people make, small changes, but consistent changes, and it can make a big difference in the long run. So we know that stress definitely signals the sympathetic nervous system, and it's just logical that the body thinks it's under a threat. It thinks it's having problems. So this is where we want to really be aware that stress reduction is an important topic we have to talk about with ourselves and with others, because that can make a big difference. People sometimes, in our mind, how we perceive the world around us. Okay, the RAS are really saying, how can we reduce the effects of this? Because it says elevated blood pressure would normally inhibit release of renin, but it does not occur in the majority of patients with hypertension. So there's something that's happening that's interrupting this regulating system. Okay, and then insulin, hyperinsulinemia, that might be a new term for some of you, but that just means either a person is taking too much artificial insulin, because that's not good for them, or your body's producing too much insulin. And this all leads to a syndrome, and it's actually something that's been studied, syndrome X it used to be referred to, and we want to make sure that people are aware that syndromes are not necessarily diagnoses, but we know that it's important to start to compile the symptoms to see if they're leading down the wrong road. Okay, so as we continue here, people are many times not impressed because they just feel okay. They might even feel good with all that extra cardiac output. Sometimes it can be energizing, getting all that blood flow. But what happens is it is a silent killer. It's something that people are, by the time they get symptoms, it's severe. Okay, so fatigue, dizziness, palpitations, angina, dyspnea, these are not, you're not going to find good values if it's associated with that. And then, of course, the heart, the brain, peripheral vascular disease, kidneys, eyes, these are all areas that are destroyed and over time, and that's why, almost similar to diabetes, kind of say, is the diabetes destroying the kidneys that contributes to all these things? It's very much associated with the metabolic processes, and that's why metabolic issues are very important for us to look at that. So syndrome X, as I was saying before, or metabolic syndrome is another term that they use to describe it. Now, this is a good motivator for some people to see that the hypertrophy that develops, and that's the enlargement of the heart. And the first slide definitely shows you how it's been narrowed. And so that's part of that systemic vascular resistance. Okay, and the normal thickness in the bottom. Okay, so we have way too much hypertrophy. So it's kind of like overdevelopment of cardiac tissue, and which is going to contribute to decreased blood flow, increased systemic vascular resistance. When you look at the blood work, okay, and this is where metabolic syndrome, definitely has a layout. I'm going to see if I can find a handout for you, but I do have a few that, knowing your numbers. When we say that to people, what do they mean? It means, knowing your blood pressure, your weight, your waist circumference, your lipids, how they usually are. But now even so, they're also including things like urinalysis, where your BUN, blood urea nitrogen, don't quote a bun, serum creatinine, right? What does that look like? Okay, these things have to be monitored. Your electrolyte balance. So looking at making overall goals, okay, how can we impact that as nurses? And there are ways you can definitely impact that. When we talk to people about, getting a baseline, what is a true baseline, how to do it well, all right? Not to be afraid to monitor their blood pressure, how to reduce cardiovascular disease, risk factors, and target organ disease, okay? These would become the overall goals. Even losing 10%, when they usually say losing 10% of your body weight, 22 pounds is kind of the average. It definitely helps. It helps the hyperinsulinemia, brings down insulin levels to more normal levels, and also weight. So these are very helpful. The DASH eating plan was it's actually a dietary approach to stop hypertension. That's what DASH stands for. And it's really a very balanced way of eating. It's usually potassium rich in its design, because they've learned that in nature there's always kind of a 3-to-1 ratio of potassium to sodium, but we've reversed it through all our processed foods. We usually have way more sodium than we have potassium now, and that's part of the theory, that if you get the potassium level corrected to the sodium in that ratio, having way more potassium, it will be protective, especially for people who are resistant to medication management, because there are quite a few people that are resistant. Population Latino and African American have trouble with being regulated with medication. So, what's a good goal? Well, we don't need that much sodium. We'd be surprised. I mean, there are people who can, it's a great challenge to try to say keep it under 1,500 milligrams a day. You have to really eat fresh. That's really what it comes down to. Eat fresh. Very little, even cereal, milk. There's hidden sources of sodium. Start looking while you're home at everything that's in your cabinet and your pantries, because try to find the things that shocked you the most, that were super high in salt, that you just never expected. Okay, that'd be a great exercise. And of course, moderation, because staying within the guidelines, that's protective. Having an alcoholic beverage a day can be actually helpful for some people to kind of calm and soothe their system a little bit. It's just when we go overboard with it, because there's always that rebound effect, right? Activity, it's the ebb and flow. It's getting your body used to certain amounts of activities and creating muscle and all of that. That's very good. Our body likes to be in motion. We are not designed to be sedentary. It's bad for us. Okay, they even say the desk job, working at a desk all day long is equivalent to like the new smoker. You're not getting enough blood flow. You're not getting circulation. Okay, so that's why tobacco is not the only dangerous thing, but we definitely know it hurts the lungs. The cilia, the small little hair-like fibers that are very protective of the bronchial airways down, to the base of the lungs, and where the air sacs are. It's protective, and when you remove those protective mechanisms, now you see why people who smoke are more at risk for things like bronchial pneumonia, because they don't have the little cleaning agents to get rid of some of those dangerous bacteria that might lodge in the lungs. Okay, so that's why we always want people to learn ways to smoke cessation, reduce, any kind of patch or smoke cessation is usually a 6-month process. So, sometimes people will suddenly stop. You will meet people that I stopped, boom. Were you cutting back before you stopped? They might have been, all right? Most people can't just stop. They usually have to cut down. But there are people who can suddenly stop, and that's amazing when that happens. But nonetheless, just know most people do need some kind of weaning down, and they do better with that, okay? And the people they live with appreciate it too. So there's a lot of psychosocial factors with all of these things. Sometimes people just don't really, they don't know what to do with their negative emotions. They'd rather just not deal with them. But unfortunately, when we don't deal with them, they build up, and that's not good. So, that's where the whole feedback system here, the loop, we know we have our own little pharmacy even within our own body. But nonetheless, this is really important for you to remember that we do have a lot of medications. Some of them are in the diuretic realm, and they really just help get rid of that extra fluid volume that's building up. We have the adrenergic inhibiting agents that will probably, target more on the central nervous system, the systemic nervous system, where we're just really dealing with things that are stressful to us, right? Reduce the effects of adrenaline, that type of thing, the sympathetic nervous system, And the direct vasodilators, your nitrates, things like that. They do have long-acting nitrates that are out there as well. And there are some people that do very well on them. The calcium channel blockers, angiotensin converting enzyme ACE, again. So, we'll be posting more about that, especially in lab 2, having you do some drug cards, because it is good to look at the mechanism of action, especially when you say, well, what is contributing to this? Okay. So the goals of drug therapy are for keeping, the blood pressure, and we're really focusing on the systolic more than the diastolic, but the systolic under 150, especially people over 60 years of age. Okay. Patients under 60, usually it's, they're trying to keep the goals under, 140. So goals should be 140 over 90, same threshold used in patients 18 years or older. So that's where we're saying, okay, if it's that would be really level 1, right? So people will need treatment even through that first stage of hypertension, stage 1. And in here, just, good to know, good to read, because these are guidelines that are supported very strongly through research. And if we have treatment of systolic blood pressure less than 120 rather than 140, there's reduced risks of major cardiovascular events, okay? Almost by a third, and risk of death by almost a quarter. So if people don't learn to do it and work on it themselves, when they're put on medication, many times they're medication that'll drive them down to these levels. And sometimes the adjustment period can be tough because people will feel that less, and they may even be symptomatic of just fatigue and not really having a lot of energy. But we know that we're trying to prolong their lives, okay? So if we have people that are not responding well, that's another reason to look at the secondary hypertension, what might be affecting that in their lifestyle, smoking or alcohol abuse and things of that nature. I had a gentleman who had for years been taking mineral oil every day to help his bowel movements, and 20 years ago we were told we can no longer use that. Occasionally they still use it for enemas, like mineral oil enemas, but not orally, because again, we know the first pass effect really does impact efficacy of medication. Well, if you put mineral oil in before you start taking your meds, or even sometime within a couple hours, it will completely block absorption of your medications. So you can never do enough questioning. And I remember being in this one man's home and saying to him, you know, I was covering for another nurse, and I said, I see you have some mineral oil in the corner. Who's using that? And he said, I am. I take that every day. And I said, hopefully after today you don't anymore, because they removed that from the floors 20 years ago for nurses. We were not allowed to give it anymore because it was really making your medications of zero effect. So I gave him, I happened to have some Metamucil, no, I had Miralax with me, a little sample pack, and he was going to the doctor's that day. And I said, take this with you to the doctors, and please talk to him about what I've just said to you, that you're no longer to be using mineral oil. And the next time I saw him, he said the doctor said he wished he knew 20 years ago that this patient was doing that, because all his meds were constantly having to be titrated up higher and higher, which is expensive, and it takes a toll on the body, and they were not even, probably the majority of it, not being absorbed. So, always watching people and educating, making sure we're doing blood pressures in the proper way, proper technique. I talked about that last time, but keeping that arm supported, making sure that she's doing it. I think it looks like, I guess it's the left arm there, but we definitely want to use a left arm first, but sometimes we need to use both initially, right? So if you're going to do that, it says use the arm with the highest blood pressure and take at least 2 readings, at least 1 minute apart. Wait for at least 1 minute between readings, and allow the blood to drain from the arm. Prevents inaccurate readings. So we don't want to take repeated blood pressures in the same arm. Usually, twice in a row, and then give it a break. But that's where we really do want to look at the arm with the highest blood pressure, because left should be the highest because it's the closest to the heart. But on occasion, the right arm or the other arm may be higher. So that's the one that becomes your baseline. And it has to fit too. The cuff has to be the proper size, because if it's too tight, it's going to drive up artificially that person's blood pressure. If it's way too loose, it's going to do the opposite. It's going to make it artificially low. And if bilaterally the blood pressure measurements are not equal, that's a good point. You need to document that and monitor it, because that might be the earliest sign of an aortic aneurysm. If somebody has a dissecting, and I had this only happen once in 35 years of nursing, but this woman had a dissecting aneurysm, and we were flying her to the immediate county hospital that had a cardiothoracic team to repair it. And it was a sad situation because the woman was a widow and she really didn't want heroics, but nonetheless her blood pressures were dramatically different in each arm. So that was a sign that it was actively dissecting. She was an active bleed. So that's why we do both arms. That's why you should also check, lying, sitting, standing on someone who's at a risk for orthostatic hypotension. You just get a baseline. Is this person there? It might be a chronic situation for them, but it's something important, again, to document. So, do we ever use, anything but the upper arms? Yes. You can use the forearm, you can use the wrist, but it definitely makes it a little bit more challenging to hear. So that's why, we like, for blood pressure, using a stethoscope to obviously use the brachial artery. It's easier for hearing. But for Doppler purposes, those other sites are acceptable. The right position that somebody's in. Can't stress this. So practice this with people in your life. That their arm is straight out. Usually use a table, or you're going to have to support it, and make sure that their arm is at pretty much their chest level, and also their feet aren't crossed. It's kind of like when you go in for an automatic blood pressure into like a Sam's Club or Walgreens or someplace. You have to slide your left arm in such a way and palm up, and you can't do it any differently. So just remember, we have to kind of automate that for somebody when we're trying to get a good baseline. So it's all about getting that good baseline. And again, we have to be aware too, people are intimidated many times in medical settings, and they'll get that white coat hypertension. So then you'd have to teach them how to do it at home. And some of them will be very good. They'll be meticulous about doing it at home properly, and they'll find out, gosh, they have a great blood pressure. So that's why sometimes people do have to be aware of that as well. Okay, so, teaching. How adequate do people get taught? I question that. Also, people who have not really had good exposure in the healthcare system may have gotten a lot of, really quick checks, screenings, and that's the extent of their health history. Very poor, whether it's emergency room visits or screenings somewhere. They've really not been cared for in a primary care sort of way. We have to really slow down for someone like that and take the time. Makes a big difference. So hypertension in older persons, you just have to remember, yes, there's an increased risk with age, and sometimes it's looked at a little differently too. We know the lifetime risk of developing hypertension is 90% for middle age, 55 to 65 and older age, or over 65, right? So it's basically, we have a lifetime risk very high, especially in our society. And we want to really try to reduce that as much as we possibly can. So that's why we have to monitor it and look for ways to modifiably correct that and adhere to treatment, okay? So a good point here, the older adult who's taking an antihypertensive medication, absorption is a big issue, right? So that's why we have to find something that works for them and monitor them to see if that medication may need to be changed, and look for things that might be interrupting the absorption of that too, okay? And it's very challenging, but we know too that sometimes people have that widening pulse pressure, so we're really watching the systolic. The diastolic may drop lower and lower, which is not necessarily good either, because that's that widening pulse pressure, which is usually an indication of advanced cardiovascular disease. Okay, so you're working against that too. So if we can't fix some of those issues, medication is not going to be just a magic. There's no magic pill to really go in and fix what's going on within the system. It's going to take an all-out effort. Not impossible, but very, very challenging. Okay, so I'm going to stop there, and I am going to encourage you to, at the very end of your book, you have questions at the end of chapter 32, and the one that I really like is that first one that talks about which blood pressure regulating mechanism can result in the development of hypertension if defective. Select all that apply. And it mentions A, release of norepinephrine, B, secretion of prostaglandins, C, stimulation of the sympathetic nervous system, D, stimulation of the parasympathetic nervous system, E, activation of the renin, angiotensin, aldosterone system. So right off the bat, you're saying, okay, let's eliminate the ones that don't make any sense. B, prostaglandins create vasodilation. Remember how I said they actually increase pain? That's why a lot of women, even with periods, sometimes medications that attack the prostaglandins help, because you don't want all that blood flow going to the uterus at times. It can create a lot more pain or injury, like any injury site. So we don't want a lot more pain, blood flow there. So just think prostaglandins increase blood flow, not good. Also contributes to migraines too. That's why when we take migraine medication, it's vasoconstrictive. The other is the stimulation of the parasympathetic. Well, that's rest and digest. So no, that wouldn't make any sense, right? Those are the things we need to work on more to get our system to calm down. So Really, the release of norepinephrine, yes. Sympathetic nervous system, yes. And activation of the RAS, renin-angiotensin-aldosterone system. Hopefully that makes sense to you, because if you get that, you've got the patho. All right, so we're going to stop right there. And I thank you for your attention, and we'll get through the semester. Hang in.